How's it going, guys? We have a difficult question for GIT Pulm Step 1, pass level question, pediatrics 2CK. Neonatal male, born 40 weeks gestation at term, coughs up milk with initial feeds. He's not cyanotic while attempting to breastfeed. He appears pink. Question wants to know which following most appropriate next step in diagnosis. Let's just hop to the answer choice here. Choice A, abdominal ultrasound, wrong fucking answer. First two, what we do for pyloric stenosis. Okay, this can be described as forceful / projectile non-bilious vomiting. And the reason it's non-bilious is because the pylorus is proximal to where the common bile duct enters the duodenum, so we're not going to have bile within the vomitus. If you do an ultrasound, you could see an olive-shaped mass. That can even be palpated in the abdomen for pyloric stenosis. Wrong fucking answer. Choice B, abdominal X-ray, wrong fucking answer. So this is what we're going to do for duodenal atresia, annular pancreas, showing this double bubble sign. If we had bilious emesis. Okay, so I mean, so far this is past level stuff we're talking. If you have forceful vomiting that's non-bilious, pyloric stenosis, do an ultrasound. If you have bilious vomiting, then you're going to think 9 times out of 10 duodenal atresia, 1 time out of 10 annular pancreas. Don't forget duodenal atresia can be associated with Down syndrome. Okay, Downs can cause duodenal atresia as well as Hirschsprung, but they can just be idiopathic. Wrong fucking answer. Choice C, gastrograph and swallow, wrong fucking answer. Okay, so this is just a water-soluble contrast swallow. Just threw this in here to be fancy because when students aren't sure, they choose weird-sounding shit. For 2CK, you could know that if you have suspected esophageal perforation, such as iatrogenic perforation following an endoscopy, then you would not do barium. Okay, because if you have a potential esophageal leak, barium can leak out and cause mediastinitis. You would use gastrographin instead. It's water soluble. That's pretty much the factoid you need to know. At the same time, or conversely, if a patient has aspiration risk into the lungs, then you wouldn't use gastrographin because this can cause pneumonitis / ARDS. You'd use barium in the setting of suspected aspiration. Point is, wrong fucking answer. Choice D, insertion of NG tube, correct answer. Diagnosis here is going to be tracheoesophageal fistula. Okay, so the kid's coughing up milk with initial feeds. You're going to insert an NG tube through the nose, and that's going to hit the proximal blind pouch of the esophagus, where you have the distal esophagus that has a fistula with the trachea. Okay, now I threw in this obscure detail about while he's breastfeeding, he appears pink. Which could be if the neonate is blue while breastfeeding and then pink upon crying detaching from the breast, that is called choanal atresia, which is part of charge syndrome. The nasal choanae are just the nasal passages, so there's non-patency of the nasal passages. Doesn't change our answer, because even if you did think it's choanal atresia, it's still insertion of NG tube, where you can't insert it through the nose in that case. So real quick, upper GI series, wrong fucking answer. This is where you have, you swallow a contrast and then you do x-rays to visualize the upper GI tract. This is done for congenital midgut volvulus. They can show you a corkscrew image, and the answer can just be failure of rotation of proximal bowel. Or they can not show you an image, give you a big, long 15-line rambling paragraph where you have no idea what's going on. And then the last sentence, they just say, an upper GI series is performed, and you're like, oh, that's the one that's done for congenital midgut volvulus. So that's very important for the pediatrics component. Just saying for step 1 as well, in addition to PEDS for 2CK, you should know that volvulus and intussusception can actually present exactly the same way, which surprises some students. They can both present with intermittent squatting, crying, vomiting, blood in the stool, bilious emesis. If they happen to do an x-ray, which is not classic for the diagnostic sequence, in both you can see dilated loops of small bowel with air fluid levels, non-specific descriptor that means obstruction of the small bowel. So the way you differentiate is intussusception has a mass, classically right lower quadrant, sausage shaped, whereas volvulus has no mass. Wrong fucking answer. You know the deal. Need to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.